On behalf of DGF Dwarka, I welcome you to this session. So today's topic is prevention of cervix. On your screen, ladies and gentlemen, are some females, as you can see. The first one is a comedian, second is an Olympian. The third is Judy Gordon. I think she's the most famous. This lady was called Madonna of the East. If you are a fan of science fiction, K.D. Kenwood. This one is a member of parliament, was a member of parliament in US, and nameless, countless Indian females. They all have one thing in common, that they all had cervix and they did not survive. So with these grim words, I like to share the burden of cervix. It does not spare anyone, black, white, yellow, brown. It is the fourth most cancer among females. 60,000 plus cases and 34,000 deaths were reported globally by this cancer in 2020. 85% incidence and 87% deaths occurred in low and middle income countries. And in India, one death occurs every 7 minutes. And it is second most common cancer in India at the age of 15 to 44 years. And it is projected that 1 in 53 women would experience cancer cervix in India as compared to 1 in 100 in most developed region of the world. WHO gave this call, cancer cervix elimination by 2030 in November of 2020. And the aim was to reduce the incidence by less than 2 cases per 1 lakh women years. And for this, the target was 90, 70, 90 for all countries, which meant that 90% girls fully vaccinated with HPV vaccine by the age of 15. 70% of women screened using high performance tests by the age of 35. 90% of the women identified to have cervical disease, cancer disease treated, which include 90% women with pre-cancer treated and 90% women with invasive cancer managed. For this, first let's talk about the vaccination against HPV virus. And as Dr. Leena also quoted this by Nobel Prize winner Helad Hussein, he got Nobel Prize for his work in showing HPV DNA causes cervical cancer. The cervical cancer does not and will not develop in absence of persistent presence of HPV DNA. There are hundreds type of HPV, 15 to 20 are oncogenic, and high-risk DNA is detected in 99% cases of cervical cancers, and mostly they are type 16 and 18. Low-risk HPV 6 and 8 cause benign and low-grade CIN, genital tract, laryngeal papilloma. There are also, HPV has been implicated in many other cancers, both male and female. So now type of vaccines, there are 3 types of vaccines which are available in India, which is a bivalent, which is Cervix. Then there is this quadrivalent vaccine, Gardasil, and now the 9-valent vaccine is also available, which is by the name of Gardasil 9. So in India, the license to use is between 9 to 45 years, and preferred target group is 9 to 14 years. In less than 15 years, number of doses are 2, that is 0 and 6 months. And it has been said that any time between 5 to 15 months, the second dose can be given. From 15 to 26 years, it is a catch-up vaccine, 3 doses, 016 for bivalent and 026 for quadrivalent and 9-valent. In older group, that is more than 26 years, 3 doses. But in sexually active women, the vaccine has reduced efficacy and we should concentrate more on screening rather than vaccine. Now we come to the screening. It is a curable disease with well-established long precancerous interval. And objective is to prevent the invasive cancer from developing by detecting and treating women with CIN 2 and 3. So good quality screening test, prompt diagnostic investigation, and appropriate treatment and post-treatment follow-up should be done after screening. And even if the women is vaccinated for HPV, still cervix screening needs to be done. So many guidelines, different recommendations. So today I will only talk about the Indian scenario. where we have these tests available: cytology, HPV DNA, VIA, and VILI. And depending on settings, available tests, cost, and feasibility, any of these tests can be done. So talking about cytology, conventional or liquid based, whatever is available, and the strength it has proven effectiveness in preventing CS cervix. It is widely acceptable. Training and methods are well established. It has very high specificity. In fact, highest specificity of all the tests that are available. But there are certain limitations. It requires infrastructure. Patients get lost to follow up. Quality control and assurance has to be there. Interpretation is subjective. It will depend on the pathologist, and the women need to make multiple visits, getting the report and the next test, and it is a little less sensitive. The next is HPV DNA, and according to these guidelines, they recommend RCOG, WHO, ASCCP, they recommend this as a primary test. And it is a simple test. Results are very definitive. There's no room for error. It is highly specific, less than cytology, but still highly specific. Self-sampling can be done, and it prevents more precancers and cancers. Screen and treat clinic can use this HPV DNA test for the treatment. And WHO says that regular screening after 30 years, every 5 to 10 years by HPV DNA. Limitations are almost same as cytology, that you need an infrastructure, quality control. It has a high cost, results again not available immediately, and it is less sensitive. Now coming to VIA, 5% acetic acid you apply on cervix, observation at 1 minute. It is very simple. It is very inexpensive. It is easily available. Even if you don't have other tests, in any clinic, in any remote area, acetic acid is available, and this test can be used. Minimal infrastructure is needed, brief training, and results are immediately available. And screen and treat and see and treat actually can be done if it is there. You see, and then you just treat. Limitations, again, quality control. Interpretation is subjective. Many gynecologists, different gynecologists will have different interpretation, and it is not appropriate in postmenopausal women. It has low sensitivity. So which test? So I came across many Indian studies. One of this was done in AIMS, and they said that sequential training testing, combination of VIA and HPV, followed by colposcopy and directed biopsy for diagnosis, gives combines economic viability with high scientific fidelity. Then there's this study by Mishra in International Journal of Preventive Medicine, which said that.
Yeah. So as we have seen, screening is a very important part in this. Cervical cancer is a curable disease with a well-established long pre-cancerous interval. And objective is to prevent the invasive cancer for developing by detecting and treating women who have CIN 1, 2, and 3. The good quality screening test, prompt diagnostic investigation, and appropriate treatment and post-treatment follow-up, all of these are very important. Women who are vaccinated with HPV vaccine, they will still need to be screened for cervical cancer. The screening cannot be done with. It has to be kept in a follow-up. Now, there are different guidelines and different recommendations. And as Dr. Geetu was saying, in the Indian scenario, cytology, HPV DNA, VIA, and VILI, they are very important. And depending upon the setting, the available test, the cost, and the feasibility, we have to see it. The conventional or liquid-based cytology, the strengths are the proven effectiveness, widely acceptable. It is widely acceptable. Training and the method, they are well established. All of us know how to do it, and it is a high specificity. Although the limitations are, it requires proper infrastructure. The lab has to be there. Sometimes the patients, they are lost to follow, and quality control and assurance. The interpretation of the subject, that is also the limitation for this. The person has to follow multiple times. Hpv DNA, this is a very important tool. The strength site is very simple.
मैं please give you कुछ काम है?
It is highly specific.
अभी कुछ नहीं है ना pending?
And self-sampling can be done. The limitations are obviously again the infrastructure, the quality control and assurance, and the high cost of Hpv DNA. The results are not available immediately, and it is slightly less sensitive. Via. It is very easy to do. You just require 5% acetic acid. We have to apply the 5% acetic acid on the cervix. We have to observe for the acetowhite areas after 1 minute. And from the acetowhite area, we can conduct the biopsy. Now the strength side is very simple, inexpensive. It is easily available, requires minimal infrastructure. It can be done even in the rural settings. A very brief training period is required, and even the ASHA workers, they can be trained for it. The results are immediately available, and immediate treatment, like Dr. Shada ma'am said, screen and treat, that can be provided.
Now we can't hear you. Can you again log in?
And the wire, can we go on to the next slide?
Went off after that. The resource-based cervical cancer screening.
The resource-based cervical cancer screening, the recommendations by Foxy, the good clinical practice recommendations are as such. There is it is divided as per the modality, the target age group, age to start, and the frequency at which it has to be done. Now we have two types where there is a good resource setting and there is a limited resource setting. The modality used in a good resource setting can be Hpv Dna, where the primary Hpv Dna, and it can be done along with co-testing with the cytology. So both HPV and cytology can be done, or cytology alone can be done, colposcopy and biopsy, or via. In limited resource setting, we can just do via or a colposcopy with or without biopsy. The target age group is 25 years to 65 years in good resource setting, and in limited resource setting, 30 to 65 years. Mostly in postmenopausal women, via may not be very effective. The age to start, the LBC or the pap smear, it can be started at 35 years, and primary HPV can be done starting from 30 years. In limited resource setting, from 30 years onwards, we can start. Frequency, and for primary HPV or along with co-testing every 5 years, whereas cytology can be done every 3 years. In limited resource setting, every 5 years, at least 1 to 3 times in a lifetime. Now, when to stop? 65 years with consistent negative results in last 15 years. Women with no prior screening, they should undergo test at least once at 65 years, and if it's negative, they can exit the screening process. Follow-up method after treatment. Now, HPV testing is preferred, or cytology at 12 months, that is 1 year, or in limited resource setting, via can be performed at 12 months. Yes. Welcome, Dr. Geetu. Now, I think you can take over.
Yeah, she can take over.
So, in patient who have undergone hysterectomy, if it is for benign causes, no need for screening unless there is a previous history of CIN. And if indication is unclear, suppose a patient comes that we had a hysterectomy, but we don't know the indication, then clinician discretion can be used to screen. And if in the hysterectomy report, we get the report of CIN, can I have my screen? Then we need to do HPV screening at 6 and 18 months. So a little word about colposcopy. It is a second test for triage. Whether to do it report-based or risk-based is open for discussion. And see and treat clinics can use this. Patient is referred with an abnormal cytology report. Colposcopy is done. And if there is a high-grade lesion, that is a modified Reed score of more than 3, simultaneous treatment can be done with excision or ablation. And there's very low probability of overtreatment because she already has a report with her. And we can have analysis of biopsy and excision specimens later. Now, what is the future? There's a role of artificial intelligence, which is automated visual evaluation That is that colposcopy report is sent to a computer and they give a report to you. And automatic neural networks are being developed, and hopefully we will see that in future, which will help us in diagnosis. Thank you. That was my talk.